Bismillahirrahmanirrahim. Assalamu alaikum, ladies and gentlemen. My name is Dr. Fuad Hameed and I welcome you all to this session on nutritional factors in selected diseases. By the end of the session, the participants should understand about the nutritional factors which influence the following diseases: cardiovascular disease, diabetes, obesity, and cancer. Well, I start off with the cardiovascular diseases. It is now generally agreed that diet governs many situations favoring the onset of heart disease, particularly coronary heart disease. Of all the factors associated with coronary heart disease, example plasma cholesterol, high blood pressure, cigarette smoking, lack of physical activity, plasma cholesterol has a very high statistical significance with incidence of coronary heart disease. And the risk of coronary heart disease appears to increase as the plasma cholesterol concentration rises. Various studies have supported the role of elevated blood levels of cholesterol and low density lipoproteins, which are LDL, in the development of atherosclerosis. And geographical studies have also shown that there is no population in whom coronary heart disease is common that does not have a relatively high mean level of plasma total cholesterol in adults. And these observations have been reinforced by metabolic studies. In addition, trials of the effect of dietary changes on coronary heart disease have suggested that altering the fatty acid composition of the diet in favor of the greater intake of polyunsaturated fatty acids and less intake of saturated fats, while restricting the intake of fat calories to less than 30% of the total calories, may lower the risk that coronary heart disease will subsequently develop. The evidence of association is now so strong for cholesterol and coronary heart disease that the WHO, World Health Organization Expert Committee, considered its effect to be causal in populations, although this cannot be claimed yet for individuals. As far as the World Health Organization Expert Committee is concerned, it concludes that there is a well established triangular relationship between habitual diet, blood cholesterol levels, and coronary heart disease. One of the current reports of the expert group of on working on this on nutrient requirements and recommended dietary allowances also endorses these views. So the first disease which I am going to discuss with you is cardiovascular disease. I have highlighted the importance of cholesterol. In all the subsequent slides, I will not be discussing the pictures or the graphs or the tables or the infographics which you see in these slides. You can go through them yourself as well because I won't be reading the slides. But I might highlight a few points in each slide. As far as cholesterol is concerned, it occurs in all foods of animal origin and part of it is synthesized in the body. The plasma cholesterol is determined by the amount absorbed from food, the amount synthesized in the body, and the third is the rate of catabolism and excretion in the bile. And there is also a fourth source, intestinal reabsorption of bile acids, and finally the equilibrium between plasma and tissues. The extent to which cholesterol intake influences total cholesterol levels is highly variable. So you can see in this slide that 1 out of every 2 women has high or borderline high cholesterol. So all these people who have high or borderline high cholesterol are predisposed to cardiovascular disease. The second thing, which is very important from cardiovascular diseases point of view, the nutritional factor is lipoproteins. And cholesterol is carried in the plasma. Lipoproteins and lipoproteins are divided into four major classes, which are chylomicrons, very low density lipoproteins, which we use the abbreviation VLDLs. Then low density lipoproteins, the abbreviation we use is LDLs, and high density lipoproteins, which are also called HDLs. And the total serum cholesterol is the sum of the cholesterol in three lipoprotein fractions, meaning in VLDL, LDL, and HDL cholesterol. And most of the serum cholesterol, close to 50%, is in low density lipoproteins LDL, whereas LDL is dominated by its cholesterol content. VLDL is dominated by its triglycerides content. LDL has been shown to function in the delivery of cholesterol to body cells, and excessive level of LDL thus leads to the accumulation of cholesterol in tissue cells, particularly the smooth muscle cells of the vascular system. And it is thus involved in the atherosclerotic process. In contrast, HDL functions in the removal of cholesterol from cells. And this mechanism underlines its protective effect in coronary heart disease. From long-term observations, it became quite clear that HDL levels, the higher they are, the more protective they seem to be against coronary heart disease. Then another important factor are fatty acids, and in populations where the plasma cholesterol is high, there is also generally a high consumption of saturated fats. Clinical studies which have been conducted on selected volunteers under well-defined conditions clearly demonstrated that a high intake of saturated fatty acids over several weeks or months cause an increase in plasma cholesterol. And the cholesterol raising effect of the cholesterol raising effect is mainly produced by C12, C14, and C16 fatty acids. And then there is stearic acid, and fatty acids with less than 12 carbon atoms have a smaller effect on plasma cholesterol. The mechanisms by which these saturated fatty acids act possibly on cholesterol synthesis is not fully known yet. In this slide, you can see what are the good fatty acids, or what is the good cholesterol, bad cholesterol, and the ugly cholesterol. So the good includes monosaturated and polysaturated fats. The bad is the saturated fats, and the ugly are the hydrogenated oils or trans fatty acids. Dietary unsaturated fatty acids with two or more double bonds have been shown to lower plasma cholesterol, and the mechanism of reduction of serum cholesterol by polyunsaturated fatty acids is again not clear, but includes reduced synthesis of very low density lipoproteins, VLDLs. And the proposition has often been made that a low HDL LDL ratio favors the development of atheroma, thus favoring the onset of coronary heart disease. As far as polyunsaturated fatty acids are concerned, example linoleic and arachidonic acids have an additional role to play, and that is to inhibit platelet aggregation and thus prevent thrombus formation. And recent research indicates that arachidonic acid and metabolites in the vascular endothelium to form two important metabolites, namely prostacyclin and thromboxane. And these two compounds have opposing effects on the cardiovascular system. Whereas thromboxane induces platelet aggregation, prostacyclin inhibits the same and prevents intravascular thrombus formation. Researchers have also suggested that generation of prostacyclin is the biochemical mechanism underlying the well-known ability of blood vessels to resist platelet aggregation. And linoleic acid, which is the main precursor of arachidonic acid, is therefore regarded as the body's best bulwark against coronary heart disease. So, in short, I will say that essential fatty acids have in the last decade come to be regarded as of major importance in clinical nutrition. It has also been shown that cholesterol in blood can be reduced by controlling the amount of type of fat in the diet. And however, several populations, particularly in Africa and in South Pacific, have intakes of fat similar to those observed in Western countries, but the average plasma cholesterol level remains below 200 milligram per deciliter, and coronary heart disease is rare. Now, here I will like to point out that then there would be other factors in Western countries, which could be stress, which could be lack of exercise, and several other factors. Maybe diabetes could be one factor which contributes to coronary heart disease over there in those countries. It has further been argued that the discrepancy may be due to favorable intrinsic, possibly genetic, mechanism for lipid handling when receiving a diet shown experimentally to raise total cholesterol. And this illustrates an important interplay between dietary and genetic determinants of individual blood cholesterol levels. Further evidence is emerging that ischemic myocardium may not metabolize all fatty acids equally, and that the accumulation of some of these in the myocardium may be more closely associated with a certain cardiac death. Then another is I have already discussed these, the dietary unsaturated fatty acids, and I think these are the ones which we should consume because these will definitely lower the risk of cardiovascular diseases among individuals who eat more dietary unsaturated fatty acids. And we should limit the saturated fatty acids, and we should avoid the polyunsaturated fatty acids. Again, the same slide which I shared with you earlier, and over here I am focusing on polysaturated fatty acids, that these are the ones which we should utilize, and which are, I would say, friendly to the cardiovascular system. Then another important component is the triglycerides. And in some countries, even national triglyceride days are celebrated. And in USA, 1 in 3 Americans die of cardiovascular disease. And that's one death every 38 seconds. And high triglycerides are associated with cardiovascular risk, even in people with well-controlled bad cholesterol, LDLQ. And in case if your triglycerides are high, or you see a patient whose triglycerides are high, then you need to investigate that patient further, because that patient has risk of heart disease. In a very large proportion of individuals with a raised cholesterol level, the blood concentration of triglycerides is also markedly increased, and some workers have indeed claimed that correlation between triglycerides and coronary heart disease is as good as that between total serum cholesterol and coronary heart disease. And it has been shown that triglyceride levels act as a significant independent risk factor for coronary heart disease. So when you are getting the lipid profile of a patient done, you also need, in addition to cholesterol and the lipoproteins, you also need to focus that what are the triglyceride results, and are these within range or above range. And the most important determinant of triglyceride level is the activity of the enzyme lipoprotein lipase in the endothelial lining of the capillaries and in a variety of tissues. And this enzyme removes triglycerides, particularly from the very low density lipoproteins, and converts those to the lipoproteins of higher density. And in certain genetically determined diseases, this enzyme may be absent, and a reduction in its activity on a reduced capacity to deal with or a reduced capacity to deal with the increased levels of triglycerides may be important in more common diseases such as diabetes, where high concentrations of triglycerides are often observed. Then you can also see in this slide, as far as triglycerides are concerned, this is an infographic. You can go through it in your leisure time. It's very informative, but again, I have to stick to to the contents of my session today. So if I even start discussing this one infographic, it will take me a whole session to discuss this infographic. Then, as far as cardiovascular disease is concerned, carbohydrates are also of prime importance, and coronary heart disease rates are lowest in populations eating high carbohydrate diets. And support for the hypothesis that consumption of complex carbohydrates may decrease the risk of coronary artery disease, heart disease, comes from historical trends of food consumption patterns and mortality rates in developed countries, especially in the United States. And it is generally recognized that such mortality rates were quite low until about 1920s, and after 1920s in those countries there was a steady increase in the mortality rate until 1968, when again a decline began. And the principal nutritional change that has occurred since the early 1920s has been a decrease in the consumption of dietary carbohydrates. So then from this you can well imagine the importance of carbohydrates, and further this support comes from feeding studies. A decrease in serum cholesterol was observed during the vegetable feeding period, and neither high carbohydrates nor high sucrose feeding has induced atherosclerosis in animal studies. And an inverse association of fiber intake with the risk of coronary heart disease has also been observed. But when we talk about carbohydrates, of course, there are some carbohydrates which are detrimental, and there are some which are beneficial. And for every 10 grams of carbohydrates, at least 1 gram of fiber should be present. For every 1 gram of fiber, no more than 2 grams of free sugar should be added. Then another important nutritional factor which affects cardiovascular diseases is salt. And there are good and consistent correlations between dietary sodium intake and the incidence of hypertension. Thus, the higher the incidence of highest incidence of hypertension is found in Japan, and especially in North Japan, where the sodium intake is about 400 nanomoles per day, while primitive societies ingesting less than 60 nanomoles per day have virtually no hypertension. And susceptible individuals in primitive populations who change from low to high intake of sodium have been found to develop hypertension, and hypertension can be successfully treated with a drastically low sodium diet, less than 100 nanomoles per day. And as far as the World Health Organization is concerned, it recommends reducing salt intake to less than 5 grams per day, which means less death, less disability, and suffering from heart diseases and stroke. So with this, I conclude the first selected disease, which was cardiovascular disease. I have discussed the different nutritional factors which positively or negatively affect cardiovascular diseases. The second disease which is of prime importance is diabetes. In a diabetic, there is impaired metabolism of glucose in the body, which leads to excess of glucose in blood and the urine, and insulin helps in checking and maintaining the level of glucose in blood. Insulin deficiency may lead to accelerated utilization of energy reserves from fat stores, and the fatty acids are oxidized by liver to ketone bodies. Excess of these ketone body leads to their accumulation in urine. This condition is known as ketoacidosis and can result in diabetic coma as well. And due to insulin deficiency, excess of fatty acids are converted to triglycerides, and in diabetes, these accumulate in the blood. Insulin is also important for synthesis of proteins, and deficiency of insulin leads to muscle wasting in case of diabetes. Studies have been conducted in England which showed that diabetes ate an average 1000 kilocalories per day more than diabetics ate more than non-diabetics, and it was also found that most diabetics were in non-manual occupations, like their jobs were kind of sedentary jobs than non-diabetics, and the diet of diabetics did not appear to differ in any marked way from that of non-diabetics except in quantity, and there is no sound evidence that any specific dietary factor is diabetogenic. But of course, sweets and high sugary foods are the ones which contribute towards development of diabetes, and malnutrition related diabetes mellitus has recently attracted attention of physicians, and protein deficiency may be involved in the pathogenesis of some forms of diabetes. Then excessive consumption of alcohol can increase the risk of diabetes by damaging the pancreas and liver and by promoting obesity. In this slide, you can see the different food items and their glycemic index, and the serving size in grams, and how does each food affect the blood glucose compared with 1 4-gram teaspoon of table sugar. So you can well imagine that like if we talk about basmati rice, it has a high glycemic index of 69, and if a serving of 150 grams is taken, so you can count these tablespoons in front of this. These are 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So 150 grams of basmati rice is equivalent to 10 teaspoons of table sugar. So you can well imagine that the glycemic index is quite high, and as far as potatoes are concerned, they also have a very high glycemic index. Similarly, French fries and baked potatoes have a high glycemic index. And if you see in this slide, after the glycemic index, we have the serving size, and then are the number of tablespoons of sugar which each serving of this particular diet have. So say for example, if we talk about French fries, if we take 150 grams of French fries, these are equivalent to 7.5 teaspoons of sugar. You can also go through this slide in detail later on. And there are some, in addition to egg, which does not have any sugar in it as such. Of course, it is the best source of proteins. There are also other foods in the very low glycemic range, which would be chicken, only fish, almonds, mushrooms. Further discussing diabetes, if we talk about reduced carbohydrate intake, reduction in carbohydrate intake would reduce circulating insulin, and it will reduce liver fat and reduce insulin resistance. thus reversing type 2 diabetes. And similarly, if reduce carbohydrate, we reduce the intake of carbohydrate, this will reduce circulating insulin. This will help us lose weight, and it will, if we lose weight, it will further complement in reducing insulin resistant, and then again helpful in reversing type 2 diabetes. And finally, the third pathway is that if we reduce carbohydrate intake, it reduces circulating insulin, and it reduces pancreas fat, which subsequently increases insulin secretion, and it reverses type 2 diabetes. This is a very interesting slide, and the takeaway message from this slide is to reduce carbohydrate intake if you want to improve. Either if someone hasn't developed diabetes yet, he or she can prevent diabetes by reducing carbohydrate intake. If someone is in the pre-diabetic stage, he or she can prevent from entering the diabetic stage. And if somebody has diabetes, type 2 diabetes, it can be reversed by reducing the carbohydrate intake. The third disease which I am going to discuss, or condition, is obesity. Obesity is something which is now seen in majority of the young population in developed countries. And in developing countries also, the incidence and prevalence of obesity is on the rise. As far as obesity is concerned, in rich countries and in some developing countries, obesity is emerging as a health problem, and the connection between severe obesity and premature death from diabetes, hypertension, and coronary heart disease has now been well established. So the basic cause of obesity is overnutrition. A diet containing more energy than needed may lead to prolonged postprandial hyperlipidemia and to a deposition of triglycerides in adipose tissue, resulting in obesity. It is also known that a relative insulin resistance takes place in obesity in peripheral tissues, mainly adipose tissue, while the insulin secretion is normal or increased. The demonstrated reduction in the sensitivity to insulin of the large adipocyte can be attributed to the decreased affinity of the insulin receptors, or to a reduction in their number in the cell membrane. Though a feedback mechanism, the insulin secretion is stepped up, thus leading to a state of hyperinsulinism. And from a practical point of view, all hypotheses concerning the genesis of obesity could be put down to overnutrition, to a hyperenergy food intake, and this is a sound basis for prevention and for advising therapeutic recommendations. Again, this slide is again self-explanatory, which shows the different mechanisms which lead to obesity and how they affect different or cause different diseases or complement different diseases. Of course, during fetal or infant development, if a lot of fat cells are developed or the baby becomes over fat, we want babies to look fat because they look more cute. But at the same time, the baby fat developed in those years can seldom be shed later in life. And then there are dietary factors. If high calorie intake is taken, it can lead to a lot of problems. We've already discussed this. If saturated fats are taken, if trans fats are taken, if less fiber is taken, if less fruit, vegetables are taken, or whole grain quantity is tremendously increased, or if it is in right proportions, then whole grains are beneficial. If high sugars are taken, or alcohol consumption is also leads to obesity and makes a person overweight. And this further leads to an intermediary condition. Then, of course, the third is the lack of physical activity. So if there is lack of physical activity, it can lead to obesity. It can lead to insulin resistance as well. And the intermediary condition emerging from this cycle is hypertension, dyslipidemias, insulin resistance, and finally, overweight people are more prone to cancers, coronary heart disease, stroke, type 2 diabetes, gallbladder disease, osteoporosis, and osteoarthritis. Now I come to the fourth and the last selected disease, and I'll be discussing this with you. And this is cancer. It is postulated that 80% of the cancers may be due to environmental factors, and it is possible that some dietetic factors may be involved. And existing knowledge is reviewed. I'll only be briefly reviewing the existing knowledge with you. And as far as dietary fat is concerned, population surveys have shown a strong positive correlation between cancer, colon, and dietary intake of fat. And it has been suggested that the high fat intake accounts for high incidence of colon cancer in Western communities. In Japan, recent increases in fat consumption have been associated with striking increase in rates of colon cancer. Then dietary fat is believed to increase the secretion of bile acids in the bowel, which are then metabolized by bacterial flora into carcinogens or co-carcinogens. And this is how the mechanism of action of development of cancer. However, no known carcinogen has yet been identified from feces, and the evidence is thus incomplete at the moment. I would further say that a positive correlation between per capita consumption of dietary fat and breast cancer rates has also been noted. A reduction in dietary fat may alter the risk of breast cancer, perhaps by increasing estrogen production or prolactin release. And this again slide is self-explanatory. I've mentioned these cancers, and you can see what are the precursors or which later on lead to the development of breast cancer, gastric cancer, intestinal cancer, and liver cancer. Then, as far as food additives are concerned, food additives and in certain cases also contaminants, and these food additives include preservatives, artificial colors, artificial sweeteners, and as far as contaminants are concerned, these may include pesticides, flavors, have always been under suspicion as possible carcinogens in their long-term effects. And food processing involves exposure to high temperature, oxidation, polymerization, production of nitrosamines, polycyclic aromatic hydrocarbons, etc., which affect our body and which injure our tissues. And it is thought in some quarters that nitrosamines are responsible for certain types of gastric carcinoma. And in addition, saccharin are weak bladder carcinogens. And at times we utilize saccharin instead of sugars. So one has to be very careful. Or saccharin can either lead to weak bladder, can form weak bladder carcinogens, or is a co-carcinogen in laboratory animals. But the risk in man is very small if present at all. Then aflatoxins is a carcinogenic metabolite, and coffee intake has been associated with bladder cancer and recently with pancreatic cancer as well, but causal relationships have not been established yet. So I will rest my case up till here. But I will say that mutagenic properties of food additives are under constant surveillance. In this slide, you can see about this MSG. MSG is something which was there in KNN food preparations, but probably now many packed meat companies have started removing MSG, which is a preservative and a flavor enhancer, because it also caused allergic reactions in certain peoples and was also a carcinogen. Then in this slide you can see artificial sweeteners, added sugar, then high fructose corn syrup, which is a liver killer, and that's often hidden by the term corn syrup. Partially, then we have partially hydrogenated oils, and then hydrogenated oils, and then food dyes. And red 40, yellow 5, and yellow 6 are the most common carcinogens found in children's food. A little bit more about dietary fiber. You can see in this slide what are the soluble dietary fibers and the insoluble dietary fibers, which are beneficial. These include oats, nuts, seeds, beans, apples, and berries. And the insoluble ones are the brown rice, wheat, berries, rye, kamut, then spelt, and fruits and veggies. Well, micronutrients may also have a protective influence, since cancers of the lung and several other sites have been associated with a low intake of vitamin A. The risk of stomach cancer has been related to deficiency of vitamin C, which may act by inhibiting the formation of carcinogen nitrosamines in the stomach. And trace elements like selenium have also been implicated in the etiology of cancer. So, if micronutrients like vitamin A, vitamin C, and other useful micronutrients are taken, these can have a protective effect in prevention of cancer. The last, as far as this disease, cancer, is concerned, the harmful thing is alcohol, and especially heavy drinking increases the risk of liver cancer. And it is estimated that alcohol contributes to about 3% of all cancer deaths. And some recent studies have suggested that beer consumption may be related to cancer of the rectum, but the association has not been confirmed yet. The above review of cancer and the nutritional factors leads me to show you this slide, which has been produced by the World Cancer Research Fund International. And you can go through it and you can see that what are the different things which we need to limit, like limit consumption of red and processed meat, limit consumption of sugar sweetened drinks, limit alcohol consumption, do not use supplements for cancer prevention. For mothers, breastfeed your baby if you can. After cancer diagnosis, follow your doctor's recommendations. Have a healthy weight. Be physically active. Eat a diet rich in whole grains, vegetables, fruits, and beans, which is seldom seen in household these days, because these millennials and the further generations, they are more into junk foods. And then limit consumption of fast foods and other processed foods high in fat, starches, and sugars. With this, I end today's session, concluding that in the future, the doctor will be of the future will no longer treat human frame with drugs, but rather will cure and prevent disease with nutrition. And of course, you are well aware of this saying that prevention is better than cure. I thank you all for attending this session or listening to this lecture of mine. And I end today's session with the message of the day, that there are many ways to love your body, but fueling your body with nutritious food is the highest form of self-respect. With this, I thank you. If you have any questions, you can email those questions to me and I will be glad to answer those. Thank you so much. Have a nice day. Allah Hafiz and take care.